Respected judges and delegates, a very good morning. I am Dr. Justin Prashanth, a second year MS postgraduate from Pondicherry Institute of Medical Sciences. I'll be taking you through a case of Rubeosis iridis in a neonate which we felt was beyond ROP. I have no financial disclosures. Going on to the introduction, retinopathy of prematurity is a vasoproliferative retinopathy occurring principally but not exclusively in premature newborns. The screening criteria includes the following. For Indian babies especially, birth weight less than 1700 grams, gestational age at birth less than 34 to 35 weeks, exposure to oxygen for more than 30 days, infants born at less than 28 weeks and weighing less than 1200 grams. Other risk factors include respiratory distress syndrome, sepsis, multiple blood transfusions, higher birth order, apneic episodes, and intraventricular hemorrhage. If a child is born with these risk factors, and even if the child is more than 37 weeks of gestation or more than 1700 grams, such children should be screened. Rubeosis iridis in a case of ROP occurs in Pless disease, which is characterized by dilated veins, tortuous arterioles, rigid pupil, rubeosis iridis, and a vitreous haze. With this introduction, let's go to our case report. Our aim is to report a rare cause of Rubeosis iridis in a premature neonate. A preterm female baby, 33 weeks of gestation, delivered by emergency LSCS in our hospital on 18/9/2018, the indication being absent diastolic blood flow in the umbilical artery, weighed around 1.3 kgs with an Apgar score of 8 at 1 minute and 10 at 5 minutes. Vitals were all stable. The pediatricians had noted some kind of a red spot in both the eyes, for which an ophthalmology consult was requested. When we went there and examined the eyes, we noticed vessels near the pupillary margin of the iris in both the eyes. Rest of the anterior segment of both the eyes were within normal limits, with the pupils reacting equally to light. Dilated fundus examination was done with the help of an indirect ophthalmoscope, which showed retinal avasculature in zone 3 of the retina, which was quite normal given the gestational age of 33 weeks. This is the picture of the eye of the baby showing dilated veins near the pupillary margin of the iris. I'm sorry for the poor quality of the picture because we had taken it with a phone and whatever was available at that point of time. And this is the fundus of the child with a normal disc and a normal posterior pole, and we also did a B scan for both the eyes for the child, which was quite normal. At this point of time, we had ruled out retinopathy of prematurity as a cause of Rubeosis iridis. So we decided to follow up the child with nil intervention. When we followed up the child 10 days later, these were the following reports that was available to us. You can see that the platelet count, protein S, protein C, antithrombin 3 values were significantly reduced when compared to the normal values. The child was diagnosed with hereditary thrombophilia, which had led on to disseminated intravascular coagulation. So for this condition, the pediatricians had transfused 2 pints of platelet on day 7 and day 8 of life. When we examined the child on the 10th day, we noted that the vessels on the iris in both the eyes had completely regressed. With these clinical findings, we came to a clinical diagnosis of both eye persistent fetal vasculature with spontaneous regression. But how did we come to this conclusion? Since fundus examination and B scan we ruled out ROP, we needed to consider a differential diagnosis for Rubeosis iridis in a neonate. So which were retinoblastoma, neonatal hypoxic encephalopathy, metal diabetes, Norris disease, persistent fetal vasculature, and a secondary hereditary thrombophilia, which were all causes given in extensive literature search. So retinoblastoma, there was no leukocoria in the child, B scan was absolutely normal, and to look for a retinoblastoma on 10 days of life was too early. Neonatal hypoxic encephalopathy, there was no episodes of hypoxia either during birth or thereafter, as the child maintained good saturation. Metal diabetes is considered to be a very rare cause of Rubeosis iridis as given in few literatures, and the mother did not give any history of any diabetes, nor was there any history of gestational DM in the mother. Norris disease is an X-linked recessive genetic disorder occurring principally in males, and our child was a female baby and usually presents with leukocoria, shrunken eyeball, atrophic iris and rubeosis iridis, the first three signs which was absent in our case. So, with the remaining two, that is persistent fetal vasculature with the secondary thrombophilia, was the most appropriate diagnosis for our case because of the following reasons. It presented on the very first day of life, and there was spontaneous regression of the vessels without any specific treatment for the eye. So, persistent fetal vasculature is usually unilateral according to the literature, but in our case, with the secondary component of hereditary thrombophilia, it has presented bilaterally, which is further justifying our cause of rarity. To conclude, after eliminating rare causes of ROP, of rubeosis iridis such as ROP and retinoblastoma, we attributed this rubeosis iridis in both the eyes to a combination of persistent fetal vasculature and hereditary thrombophilia, which was evident in the literature that I have referenced later. While ROP though remains the most common cause of an rubeosis iridis in a neonate, we also should consider the rare causes that I have mentioned. Moreover, rubeosis iridis as a consequence of ROP on the very first day of life is unlikely in a preterm neonate. These are my references. I would like to thank the Department of Ophthalmology and Department of Pediatrics and Neonatology of Pondicherry Institute of Medical Sciences for helping me to present this case.